Hello everyone, this is Greg Kronenberg and welcome to my Pecha Kucha presentation. I would like to start with a few pictures from Elko, Nevada, where I live, since many of you didn't seem to know where it was, and if you haven't guessed it, I really do like snow. I would like to discuss pain, depression, and coping. You may be like me and wonder how a war hero may end up like the gentleman on the left as opposed to the hero on the right. Both have experienced physical and emotional pain, but have two dramatically different outcomes. You are also probably like me and have felt inadequate in helping others who are having a tough time coping with pain and depression. It is a vicious cycle that often our pain pills and injections won't help and may actually over time worsen the person's ability to cope with what they're experiencing. Over the last decade, there has been a tripling of opioid prescriptions, an epidemic increase in opioid overdose, and a dramatic increase in opioid-related suicide. These are all examples of our inability to effectively treat chronic pain and associated depression. So what can we do? We all experience pain, both physical and emotional, at some point in our lives, but how we deal with this pain can determine different outcomes. We know pain can lead to depression and vice versa. If we have an increase in either pain or depression, the other will increase also. Therefore, it does not matter which is the cause or consequences, they both need to be treated. Throughout this fellowship, we will be learning multiple injection techniques to treat the physical side of this pain equation. But how are we treating the depression or emotional side of this reciprocal relationship? And most importantly, should we expect any long-term results if both are not addressed? We must start by identifying the depressed patient when they enter our pain clinic. Oh, and by the way, clinical data suggests that will be 40 or 50%. This means we need to get really good at recognizing these patients early on so we can address this issue. Probably the most popular and common screening tool for depression is the Patient Health Questionnaire, or the PHQ-9. As you can see, it is a very quick and easy questionnaire with only 9 questions and has a proven to be specific and sensitive to 90%, regardless of age, gender, or ethnicity. By identifying our depressed patients early on, we can start to address the depression that will be essential to the patient's long-term improvement or ability to cope with their chronic pain. Remember, our goal, while following a naturopathic model, is to guide the patient along a lifetime of health and not just acute pain relief. So once we have identified the depressed or at risk for depressed patient, how do we move forward? Turk and colleagues examined why all patients who are experiencing chronic pain are not depressed. They determined that patients' appraisal of the effects of the pain on their lives and their ability to exert any control over their lives mediated the link between pain and depression. In other words, how are they coping with their pain and impact on their lives? They found that patients who believed that they could continue to function despite their pain and who believed that they could maintain control despite their pain did not become depressed. So we need to help build our patients' coping skills. The Mental Health Wellness Week organization determined that many mental health problems begin with physical or emotional stress, which trigger changes in our brains. The goal of treatment and prevention is to reduce stress and restore normal chemical processes in the brain. Of equal importance may be addressing any negative coping skills which can hinder progress in dealing more positively with stress. As you can see, many of these negative behaviors are beyond many of our scope of practice and points to the importance of involving mental health professionals with our patients' care. I would like to mention catastrophizing, post-traumatic stress disorder, and suicide, which are specific comorbidities related to depression. It will most likely require more in-depth assessment and treatment when identified. There are several assessment tools available to assist in diagnosis, but it is imperative They are addressed because of their correlation with long-term disability. Catastrophizing is a negative emotional, cognitive, and attitudinal response to pain. It has been determined that improvements in desired outcomes cannot occur without a reduction in catastrophizing. This will require multidisciplinary and behavioral treatment implementation before we may see improvement in pain scores. PTSD is a mental health problem that some people develop after experiencing or witnessing a life-threatening event like combat, natural disaster, a car accident, or sexual assault. Because of its relation to depression, coping, and pain, it again needs to be addressed early on before success with chronic pain can be achieved. The final dimension to highlight is suicide. There is a high incidence of suicide thoughts in patients experiencing chronic pain. Although suicide is not a disorder, identifying those at risk early on can diminish long-term morbidity and mortality. Interestingly, treatment suggestions are improving sleep and coping skills. Sound familiar? So to recap, pain and depression are interrelated. Depression must be identified with special attention to catastrophizing, PTSD, and suicide. Treat depression by increasing coping strategy. Decreased depression will lead to decreased pain perception and a happy patient. I wonder if we all had a Forrest Gump in our lives, if we might not avoid the homeless man on the street and become like Lieutenant Dan, who goes on to invent Apple. Furthermore, maybe if we try to be more like Forrest Gump and have an eternal optimistic outlook, we may do more for our patients than any pill or injection. I hope you enjoyed my presentation, and I look forward to viewing yours. I find this technique to be a novel approach to presentation, and I appreciate the ability to have time for discussion this offers afterwards. Remember, learning involves communication back and forth. I know I really have a hard time just listening to a lecture without a strong cup of coffee.